Wonderful. It's wonderful that we're recording this because we have over 400 people that signed up for this today. And we're really excited to get this out to those who can't join today and are looking to join us in the future virtually. So welcome everybody to our webinar, Addressing Suicide Risk Prevention, Stigma and Support, in partnership with the American Foundation for Suicide Prevention. And a little bit about ADAA. ADAA is the leading nonprofit organization in the field of anxiety and depression. And we encourage you to take advantage of the many helpful resources on our website, adaa.org. And you'll find a list of providers that provide empirically supported treatment through our Find a Therapist platform, free peer-to-peer online support groups, a library of wonderful educational content, blog posts, really quality information. And ADA is proud to bring together leading experts in the field of mental health to provide you evidence-based mental health information, such as this webinar. So thank you for joining us in our mission to break the stigma around mental health. And my name is Dr. Deborah Kissin. I'm the co-chair of the public education. I'm the of ADAA, the Anxiety Depression Association of America, and I'm also the CEO of Light on Anxiety Treatment Centers in Chicago. And we are thrilled today to have our fabulous presenters and experts in the field. First, to introduce Dr. Alex Bettis, who is a licensed psychologist and assistant professor in the Department of Psychiatry and Behavioral Health Services at VUNC. She received her PhD in clinical psychology from Vanderbilt and completed her pre-doc clinical internship at UCLA at the Semel Institute General Child Track. Dr. Bettis has been an active member of ADA for several years and is the co-chair of the Suicide and Self-Harm Special Interest Group. This is wonderful to know, as well as the co-chair of the Elise Muskin Career Development Leadership Awards Program. And we also are thrilled to have Dr. Jill Harkavy-Friedman, who is the Senior Vice President of Research and leads the American Foundation for Suicide Prevention's research program to advance the field of suicide prevention. AFSP's research program provides funding to research grants, offers workshops and trainings to researchers, and disseminates findings to increase public awareness and support advocacy in mental health and suicide prevention. With over 35 years of experience as a clinician and suicide prevention researcher, she's passionate about translating research into practice. So just know for the format as we go, feel free to write your questions into the chat box. And we're setting aside 20 minutes at the end that we really want to get audience participation and understand what you're here to learn about. So keep those questions coming in the in the chat box. And now I'm turning over the presentation to Dr. Bettis.
Great, thank you so much. All right, I'm going to share my screen. Okay. Thank you all so much for being here today. I'm going to start us off with just a brief overview presentation to talk a little bit about what we know about suicide risk, and then we'll jump into Q&A and discussion. So a quick overview of what I'm going to be talking about today. I'm going to give kind of a scope of the problem. So what do we know about rates of suicide in the United States? I'm going to talk a little bit about risk and protective factors, as well as warning signs that someone might be at risk for suicide. And I'll briefly touch on treatment, resources, and support that are available for people who might be experiencing suicidal thoughts or urges to engage in suicidal behavior. So we're all here today because we all recognize that suicide is a major public health problem. This is true both in the United States specifically, but also worldwide. Honing in a little bit more on what we know about suicide in the United States, these are data from 2020 collected by the CDC. In 2020, we know that approximately 46,000 people in the United States died by suicide. This meant that suicide was the 12th leading cause of death overall in the United States in 2020. Although when we kind of hone in on specific age groups, we know that some age groups that kind of number climbs. So for children and adolescents in the US, ages 10 to 19, it's the third leading cause of death. In our young adult group, 20 to 34-year-olds, we see that it's the second leading cause of death. And among 35 to 44-year-olds, we see it's the fourth leading cause of death in the US in 2020. We also know that many more people will experience suicidal thoughts and engage in non-fatal suicidal behavior than will go on to die by suicide. So rates of suicidal thoughts and suicide attempts in the US across all age groups are alarmingly high and really important for us to be paying attention to. And we're going to talk about some things today that you can do for people who might be experiencing these types of thoughts or have engaged in suicidal behavior in the past. We also know a little bit about some groups who might be at higher risk for suicide. So over many decades of research, we've consistently found that there are sex differences in rates of suicide in the United States. So males are more likely to die by suicide compared to females in the US. We also know that females are more likely to engage in suicidal behavior or make suicide attempts than males in the United States. We also know that groups like veterans and people who identify as LGBTQ+ report higher rates of suicidal thoughts and suicidal behavior. And we see that rates of suicide vary among different racial and ethnic groups in the United States. I'm not going to get into the details and break all of that down, but one thing I would like to highlight that we've seen over the past several years is really an alarming increase in the rate of suicide among Black youth in the United States, as well as Asian American youth. And this is something that is getting more and more attention, as it should, both in the media and in our research. We also know from decades of research that there are several risk factors that might make someone at higher risk for suicide. So first and foremost, we know that being diagnosed with a mental health condition might put you at higher risk for suicide. So things like anxiety, depression, bipolar disorder diagnoses, difficulties with substance use and alcohol use, all of these things can increase someone's risk for experiencing suicidal thoughts or behaviors or dying by suicide. We also know that physical health conditions can put individuals at higher risk, particularly those that are chronic and disabling. Major life stressful events are also something that can put someone at risk for suicide. So experiencing a major life stressor like losing a job or going through a major relationship change, as well as sort of day-to-day experiences of things like discrimination, harassment, bullying, all of those types of stressors can increase someone's risk for suicide and might account for some of the discrepancies we see in different groups of individuals who are at higher risk for suicide. I also know that exposure to childhood traumatic events like abuse and neglect can increase risk, as well as having a family history of suicide. And lastly, we know that having access to the things that you can use to try to end your life can put you at higher risk, particularly when we think about periods of time where you're in higher levels of distress or experiencing sort of acute distress. Being able to easily and quickly access things like firearms that can be extremely lethal can be extremely risky during those periods of time. On the flip side, we also know that there are several protective factors against suicide. So having access to mental health support, both formal treatment resources as well as informal mental health support, can be protective for those who might be at risk. Also having access to social support, so having peers and family members that you feel like you can go to for emotional support and feeling connected both to those individuals as well as more broadly in your community can be protective. We also know that there are cultural and religious beliefs that promote really having a sense of purpose, and those types of beliefs and belonging to those types of communities can for some people be protective. Also having access to things that we need in our day-to-day life that are really considered basic needs of living, having access to food, clean water, housing, transportation, all of those things are really protective because ultimately we all need our basic needs to be met. And lastly, sort of on the flip side of what I just talked about, not having access to lethal means during periods that are really high stress or where we're experiencing a lot of distress can be protective. We also know that there are several warning signs that we can be on the lookout for in those that we care about, as well as in ourselves, that might indicate someone is entering into a period of higher risk for engaging in suicidal behavior or having suicidal thoughts. So things we want to pay attention to include changes in mood or behavior. These might include things like someone demonstrating increased isolation from their family or friends, engaging more in substance use or alcohol use, someone getting the things that they could use to end their life, or giving things away to the people that they care about, getting rid of possessions that are important to them. All of those might be signals that somebody is thinking about or making a plan to try to end their life. Someone showing increased expressions of anger, aggression, agitation, or irritability that are sort of out of the norm for them, or experiencing worsening depression or anxiety can be warning signs for periods of suicide risk, as well as increased feelings of hopelessness, feelings of burdensomeness, any changes that are significant in someone's sleep and their energy level or in their general social or just broad engagement in the things that they maybe typically like to do or need to do, as well as experiencing excessive guilt or shame. All of these things, if we notice these changes in people around us, that could be an indication that something's going on and maybe we need to check in and talk with them about what sort of supports they have in place. In addition, we know that people will also talk about suicide when they're thinking about it sometimes. So people who are making expressions about feeling like they want to die, they don't want to do this anymore, they want to give up, they feel like they're a burden, or life just feels totally unbearable. They can't think of any reason to live. There's no point in them being around anymore. Talking about these types of things are an indicator that somebody might be thinking about ending their life. And we want to take that seriously and listen when people are sharing these types of thoughts and this type of pain and distress with us. The good news is that we also know that suicide is preventable, and we have a lot of resources available that can help people who are experiencing suicidal thoughts or having urges to engage in self-harm or suicidal behavior. So just a very high-level overview of some evidence-based interventions that we know can be effective. So for people who are experiencing acute distress or in a period of particularly high risk, we know that there are some brief interventions that can really help people get through those periods that are the hardest. So things like safety planning, coming up with a plan for what to do when you have suicidal thoughts or wanting to do something to hurt yourself, can be a really helpful way to be prepared for when those periods of distress come on. Lethal means counseling is a part of safety planning, but also can be done outside of that, really working out a plan for how to restrict access to the things that are most dangerous and that can be really risky during periods of high risk is really important. But we also know that people really benefit from ongoing psychotherapy support to help manage and reduce suicidal thoughts and urges over time. So some evidence-based treatment modalities include cognitive behavioral therapy for suicide prevention, the collaborative assessment and management of suicidality treatment, as well as dialectical behavior therapy. All of these psychotherapy modalities have shown good evidence to be effective at supporting people who might be experiencing suicidal thoughts or have engaged in suicidal behavior. And lastly, while there is no single medication that is prescribed to treat suicidal thoughts or behaviors, we know that having appropriate medication for whatever psychiatric concerns you have can be really helpful. So getting medication support for things like depression or anxiety or bipolar disorder can be really helpful in conjunction with getting ongoing psychotherapy support. Lastly, I do want to highlight that there are several resources that are available 24/7 for people who are experiencing a mental health crisis, or for people who have a loved one who's experiencing a mental health crisis. These are all listed here, and we'll post that information also in the chat. But I will end here and stop sharing now so we can get into some more discussion.
Just quick question on those resources,
Mhm.
988 versus 911, which we could talk about later, but if someone, maybe there's just a quick explanation of 988, and if someone still does call 911, is that still available? Is there any quick, either of you guys on
Absolutely.
that? Yeah.
Sure, that's a great question. So 988 was rolled out this summer as the new number for the National Crisis Hotline. And that is a hotline that is dedicated specifically for individuals who are in a mental health crisis and or are supporting someone else through a mental health crisis and need help in figuring out what to do. So when you call that number, you're going to hear an automated message that introduces you to the hotline, and then you will be connected with someone at a crisis center near you or the closest crisis center to you, depending on where you are, to talk with a trained counselor who can help walk you through what might be helpful for you. So 911 is more a general emergency line that you can call. If you're in a mental health crisis, you can call 911. But this line is dedicated specifically to mental health emergencies and has people on the other end who are trained in how to talk to people who are experiencing a crisis.
Very helpful. Thank you so much. Okay, Dr. Harkavy-Friedman.
Hi, everyone. I'm so happy to be here. I'm just going to get my slides up, and I'm happy to be with ADAA. We've had a partnership we were looking back to see how long our partnership has been, and feels like a lifetime. And it's been a great partnership because it helps us to bring suicide prevention specifically to clinicians and researchers who are engaged in mental health work. So thank you for having us. What I'm going to do now is just talk a little bit about the American Foundation for Suicide Prevention, and then we're going to go into our panel where we address your questions. So American Foundation for Suicide Prevention was developed in 1987, and it was initiated by a few families that lost loved ones to suicide and a small group of researchers. And our mission is to save lives and bring hope to those affected by suicide. And we do this with a very comprehensive approach. And I'm the Senior Vice President of Research, and we started by funding research. But research without disseminating that work and building it into practice is just research. So we use the research findings to develop education programs, to increase public awareness, to advocate for mental health and suicide prevention efforts, and to reach others who may be experiencing suicidal ideation behavior, or maybe they've lost a loved one, or they have concern about someone, or just care about the cause. And then this feeds back to research. And because we know that research is a process of gaining information and insights. So this is an ongoing cycle. And as we funded research this year, we're funding 34 new studies for $8.2 million. And as we've done that, we've learned more. Those treatments that Dr. Bettis mentioned all had funding from AFSP at some point in their development. And so we're really excited to actually now have things like safety planning and DBT and CAMS and CBT-SP. In fact, one of the things we learned is that you have to help someone address their suicidal ideation and behavior, as well as addressing any underlying mental health condition. So I'm going to say a little more about what we do. We are a grassroots organization. We're in all 50 states, and we have a variety of programs and efforts to help on our mission to save lives and bring hope. So one is we work to connect people to research, one by funding research, but also by educating researchers and helping them in their skill development. So we have webinars. We also have a conference every other year, International Summit for Suicide Research. And we also have programs like a Research Connection program where researchers come to the community and we'll talk with the community and not just present their work, but then have a conversation. And that conversation then informs researchers about what they need to go on to study. So it's a really great program. We also have prevention education programs. We have for every age group. We have our More Than Sad program for schools, high schools, teachers, and parents. We have It's Real program for late high school, early college programs. We have Finding Hope, which is for people, the families and people who love someone who's actually made a suicide attempt. And then in our loss and healing, we have programs. We have a fabulous program called Healing Conversations, where a person who's recently lost someone can speak with someone who's a few years out from their loss. We try to match them in terms of the kind of loss that they've experienced, for instance, the relationship to the person, and they just have a conversation. So to help with the healing process and to bring hope that even when you've lost someone, you can find a way to have meaning in your life. We also have advocacy program. We have an office in DC. We advocate on the federal and the state level, and everybody can become an advocate. If you go to our advocacy center at afsp.org, you can find all of this at afsp.org, but it's very easy to become an advocate. And in fact, 988 was able to become a real entity in part because of the many letters that our volunteers, right now we have over 40,000. And so it's easy, you sign up, you put your address, and then we know who your representatives are and your senators. And if there's an issue coming up in your state or on the federal level, we'll send you a letter. You can fill in a little paragraph if you want, or send it as is. And then you push a button and we send it for you. And our policy center, you can see everything that we're advocating for. We have an amazing interactive screening program, which is an anonymous survey that many colleges and workplaces and EAPs are using now, where the organization can either send out blasts to its members or just be available, and people can take an anonymous mental health survey. And then based on those responses, they can dialogue anonymously with a trained counselor. And the goal of that program is to engage people in treatment. So the opportunity to dialogue, address resistances, and help people find help is extraordinary. Also, we have our Out of the Darkness walks. And honestly, I think this is one of the things that has really increased the conversation about suicide prevention and has literally brought it out of the darkness. So we have about 400 to 500 walks each year in local communities. You can go to our website and find them. Again, afsp.org. And the community walks are 1 to 3 miles, and it's just a way to bring people together who are passionate about the cause of suicide prevention for whatever reason. We have what we call honor beads in different colors. So if you are a lost survivor or you're experiencing, mental health issues, you can see visibly who else is experiencing what you've experienced. And then they're a lot of fun, I have to say. We also have a whole PR and communications where we bring suicide prevention to the public. We have a great program where we partnered with the JED Foundation and the Ad Council called Seize the Awkward, which you can find at seizetheawkward.org. And that's really targeting 18 to 22-year-olds, but I love it. I'm 65, so I highly recommend getting, just checking it out, looking at the videos. We have our Project 2025, where we set a bold goal to reduce the rate of suicide 20% by 2025. And we target 4 areas where we know we can reach the most people. Those groups that Dr. Bettis mentioned. Well, where do you find middle-aged men? You kind of can't stand out on the street and ask for them. Where do you find veterans? Where do you find LGBTQ? Well, 83% of people go to their primary care doctor. So we target large health systems. We target emergency departments, where almost 40% of people who die by suicide were seen in an emergency department just prior to their death. We target the gun owning community, since firearms, if you have firearms in your house, it increases the likelihood of a suicide 3-fold. And we target corrections systems, where the rate of suicide is the leading cause of death. So you can look at Project 2025 on our website as well. And then we have our wonderful chapters. We have chapters in all 50 states and Puerto Rico. And that's where the community can bring these programs to their local community. So we have the International Survivors of Loss Day, where chapters host events to bring for survivors. That's where the Healing Conversations people can be found. And it's really our community engagement that helps to raise public awareness. And then finally, we have workplace initiatives. And I saw somebody already asked a question about workplaces. And I just want to say, yesterday, we signed an agreement with OSHA to address suicide in the workplace. And you know how you have those posters on your wall about what to do in an emergency and who to go to? Well, there'll now be a poster about suicide prevention. So we work with EAPs with our interactive screening program. So as you can see, thought just came to me, we're in it to win it. We're here to address suicide prevention from every avenue, and we're always looking for new avenues. So with chapters in all 50 states and Washington, D.C., and now Puerto Rico, we are leading the fight for suicide prevention, and we welcome everybody to join us because everybody can play a role in suicide prevention. And that's why I'm so glad that you're here today and going to ask us questions, and we can help to share the knowledge that we already have. So on that note, I am going to stop sharing.
Wonderful. You both shared such helpful knowledge and resources, and I can't wait to share this with my staff, with my children's schools, and just keep, I think the more conversations like this that are had, the better off we will all be. So thank you so much for joining us today. We have a few questions that we've started off with and lots of questions that have come along the way. So I will make sure at 11:45 to switch gears depending on how this conversation goes. But I'm going to be a little selfish and start with a question that came to mind through what you guys have presented thus far. So Dr. Jill, you mentioned that something that stood out around learning that for treatment, it's critical to address suicidal behaviors, not just underlying mental health concerns. Can you tell us a little bit more about that, and for both of you guys on that topic?
Sure. I mean, it's always important to address underlying mental health conditions, first of all, because they help people to feel better, but it doesn't always change what someone does in terms of suicidal behavior. And part of that is sometimes because of things like emotional dysregulation. Sometimes that's because people don't know what else to do. And so by having these initiatives like safety planning that Dr. Bettis mentioned, you literally give people a set of steps they can engage in if they start to see the warning signs that they're going down that path. Because in a crisis, that's not a time to start trying to think about what to do. The other thing is when somebody is in that state, they lose access to their usual coping, and their thinking becomes very rigid and inflexible. We say they get like a tunnel vision. They are in pain. A lot of times they're not even thinking about dying. They just feel it's never going to stop. And that's part of the reason that limiting access to lethal means is so important. Because if they're feeling that way and there's something there, they may reach for it right away. Whereas if you make it inaccessible, first of all, it gives you time. Second of all, because of how their brain is functioning, they are not necessarily going to try something else because they may not even think of something else. But if they do, they probably won't die from it. And we know that 90 to 95% of people who make a suicide attempt do not go on to die by suicide. So if we can get them through those crisis moments, then they have a good chance of fully engaging in life with work and therapy and medication as needed.
One thing I'll add to that also, because I saw a related kind of question in the chat about what about people who might be resistant to wanting to talk about suicidal thoughts or behaviors or engage in that type of treatment. Another way into that is also making sure you're hearing kind of what's most important to them. And it might be that the anxiety they're experiencing or the depression they're experiencing is really driving a lot of the pain that then leads to these suicidal crises. So really taking into account the whole person and their whole picture and what they find most distressing can be really helpful in addressing their suicidal thoughts or behaviors as well. So we want to focus on kind of the whole picture there, and that can help increase motivation, I think.
Wonderful. So first question, and for both of you guys, either of you guys, what can somebody expect when they call into a crisis hotline? And also, can somebody call into a crisis hotline for a loved one who's experiencing psychological immense distress?
I can take it, or you can take it, which do you prefer?
Both of you guys, yeah.
Okay, so one thing that, and I think they've done a much better job of telling people with the 988, bringing that out, is that when you call a hotline, like Dr. Betta said, they can connect you with someone in your area code. But so when you call, there's probably going to be a message and then a pause. And sometimes that pause can be a while because they're trying to connect you with the local center. But it turns out that many of us have cell phones and many of us have moved around the country. I haven't because I'm sedentary, but so that your cell phone may not actually be the place they connect you with. If it's not where, if your area code is not where you are, please understand that they will connect you with someone near your area code so that they can connect you with care. And so they're going to connect you, you're going to be on hold, and then you're going to talk to a trained counselor who is going to listen and help that person to manage, to really try to understand what they're thinking and what is leading them down that path, and help them to get out of that crisis situation and to get to help. So remember, I just said that people often don't have access to their usual capacities. So by de-escalating the situation and putting some time in there, that in and of itself can reduce the risk for suicidal behavior. If you care about someone and they're at risk and you don't know what to do, you can call them and they will guide you through it. And clinicians can call them. And in fact, you can call them with the person in your office, or you can have the person in your office calling them. Please know that they will tell you to talk to your therapist, but they can also guide you to local crisis centers or to local hospitals or emergency rooms. And what came along with that 988 Act is a commitment to developing crisis centers. So people don't necessarily have to go to the emergency department, which is a medical facility, and they can go to a place where people are trained to work specifically with people in mental health crises. So there's a lot of advantages. When you call 911, which if you have to and it's emergency, the police will come. And they have a set of protocols they have to do to keep the person safe. And if you call 911 and the person doesn't have a weapon, it helps to tell the police that.
911 won't route to 988 if it's a mental health. If you call 911, you're on that track. That's actually interesting.
Police are coming. Yeah.
Okay. So,
and if they come and they put the person, they will put the person in the back of their car because that's the only safe, secure place for that person. Right. Imagine it's hard to put somebody in an ambulance with tubes and scissors and all these kind of things. Yeah. So for safety, they have to put them in the car. The more you can educate people about what will happen if you call 988 or you call 911, the better experience it will be for them.
And I see a lot of providers that are on here. And so we just changed all of our intake forms and we've changed on our website. I don't know how much that we're all changing as on the outpatient side to fully change some of our forms. And I have to say, like, I called myself just to make sure, like, is someone definitely going to answer? I didn't know what to expect. And so I think that's an interesting thing for us to get out there to all the
and please know that the 1-800-273-8255 number, if you have it, is still active.
Okay.
And the other thing is, please advocate in your states to fund 988, because some
Right.
states, that's a state issue, and some states are not funding 988.
Okay.
It's also, I think, helpful to know that there's a Spanish speaking line. So when you call in, you can get routed to that line. And if you need another language, they can also connect through interpreter services. So it's available broadly, not just for English speaking people, which is important. And if you dial 988 and hit 1, it will connect you to a line that's specific to support veterans. So those are some extra features that I think are helpful to be aware of.
And Dr. Jill, if you're in a state that doesn't fund it, but you call, they'll route you to somebody. It just,
They'll still be there, but without
someone
the
will be there.
funding. So some crisis centers are only open certain hours of the day.
That you won't
Some
have
are
as many of the
volunteer,
crisis-
some are,
okay.
so it's not as robust a system, but you will get answered, but
Right.
you may not get answered locally.
Got it. Thank you. Okay, so many wonderful questions, and we're going to get through as many as we can. And for everybody to know, all the resources are going to be sent after this is over, with links to access the presentation, as well as a lot of the resources that have been recommended. And maybe even we could do a part 2 at some point. So we're going to get to as much as we can get to today. So next question, what behaviors or key indicators should you watch if you feel someone is at risk or thinking about suicide? I know you guys addressed it a little bit, but anything else that comes to mind on that topic? Key indicators to watch
Well, guess
for.
what? You don't have to guess.
Nice.
You can actually just ask someone, how you doing?
Okay.
I notice that you're, pulling back. What's going on? So that's the first thing I would say, is you don't have to look at the person to know. All the things that Dr. Bettis mentioned, and they're also on our website, afsp.org. I'm just saying that over so you know where to go.
Yeah.
But so the first thing is, you don't have to guess. You can tell someone, I'm worried about you, what's going on. You don't have to start with, are you thinking of killing yourself? I suggest not saying, are you thinking of suicide? Because that's a very vague term that people have all kinds of interpretations of. But, and just because they say yes to their thinking of killing themselves doesn't mean that they're going to die by suicide. It means to have a conversation. You don't have to become a mental health professional if you're not one. Have a conversation, figure out what the person is really thinking, and whether or not it's if you, at any time, trust your gut. If you feel it's an imminent crisis, then call 988. But to help that person get help is the most important thing. And they can be involved in that process. They're not victims to whatever we do. When a person's thinking of suicide, the thing is to help de-escalate it and help them get help.
And we also can't underestimate the importance of just being there to listen and validate the pain that they might be experiencing, and come at it from a non-judgmental place, showing that you really want to help and you care about this person, and that work with them to find what's going to be the right support that they need. And I think being prepared, if you are going to ask the question, and I think it's really important for us all to get really comfortable asking these questions, also being prepared to hear an answer. It can be really scary to ask someone you care about if they're thinking about killing themselves, or if they're thinking about hurting themselves in some way. And it can be scary to hear yes if that's not something that you've heard before, or that you might be surprised to hear. And I think being prepared for your own emotional reaction to that too is important, and having a plan in place to take care of yourself as you're supporting someone in your life is equally important.
Yeah, and I think what you said about not being judgmental and not trying to talk them out of it, because that just puts them in the position of having to convince you why their life is not worth living. So, just listening, not challenging, but respecting that this is how the person feels right now.
Okay, thank you. Another question is, everyone who thinks about suicide or having suicidal thoughts suicidal? Are there different levels of risk of individuals who are experiencing suicidal thoughts?
So I'd like to say, if that's okay with you, Dr. Bettis, that, suicide is complex and there's never one thing that causes suicide. And even when we think about the impact of stressor, it's more as a precipitant than a risk factor. So people, for a variety of reasons, may be at increased risk for many of the things Dr. Bettis mentioned: having a mental health condition, having a physical chronic condition or chronic pain, having early childhood trauma, having head trauma, having a family history, or other genetic reasons that are not related to family history, but related to how you manage stress, how much reactive you are, or how, what pushes your buttons and how big a reaction you have. So those factors can increase a person's risk for suicide. They may never engage in that, or they may in the context of stress. And I always think of whatever stress that people contribute, say causes suicide, most of us have experienced, and most of us are not taking our lives. In a person who's vulnerable, that could be. Now, lots of people think about it, fewer people attempt, and even fewer people actually die by suicide. And that's because while there's overlap, they're not the same groups of people. So about 12 million people in the last assessment survey were thinking about taking their lives. Now, thankfully, 12 million people didn't die by suicide. So that in and of itself is evidence that just because you think about it doesn't mean that you're going to die by suicide. It probably means you're in distress, and it probably means that you could feel better with some help and some support and some therapy or treatment. But most people who think about it will not even make a suicide attempt. Most people who attempt, about 1.2 million in that same survey, will not die by suicide. So don't panic just because someone's thinking about it. It doesn't mean they're in a crisis. It doesn't mean they're at risk for suicide. It means that we need to have a conversation. And at AFSP, we have guides for how to have that conversation. Even if you're a therapist, we still need to learn how to do that.
Okay, so I'm going to switch gears now to the participants' questions, and I want everyone to know that we're going to go through the questions after as well. So anyone that we don't get through, we're going to not only post this webinar, but we'll have some kind of blog post that answers the remaining questions, and because they're all so important, we want to get the content out in a way that's going to get to all of you who've joined us today. So stay tuned. So I'm just going to kind of, when I see a theme of a few things that are coming up, try to get to those first. So we have somebody who is a PhD student from Morocco, and I usually see people attempting suicide being locked up in a mental institution or being watched closely. This is life-saving, but at the same time, very stressful for patients. So what do you think about that process?
Sure. It absolutely, we should take the decision to admit someone to, inpatient facility really seriously, and, use that as really when it's absolutely necessary, because it does, in some cases, it is necessary to keep people safe in the short term so that hopefully we can then connect them to longer term support that's going to keep them out of the hospital and help them stay healthy and safe. Also totally understand from a lot of the perspective of people who have this lived experience with having been in the hospital, it can be a really distressing experience in and of itself. And so some of the psychotherapies that we briefly talked about earlier are really designed to try to keep people out of the hospital and build up skills that are going to keep them safe. I think one thing that is also really important is really supporting clinicians in how to assess risk and make these decisions. I know personally, even in my graduate training, there wasn't necessarily a large focus on how to manage suicide risk. And I think that's true for a lot of training programs. And then it puts clinicians in difficult situations where maybe they don't feel comfortable making a decision. And I think there are a lot of different ways we could approach this problem to try to make resources more accessible, to keep people out of the hospital, to empower providers to really understand how to assess and manage this risk, and also make sure that people are accessing therapies that are going to give them the skills that can keep them safe and help them manage periods even of higher risk, without needing to go into the hospital. I think that's the ideal.
The other thing that's happening is that these treatments are being brought into the hospital, especially the shorter term interventions, so that they can be done in, average hospital stay now, I think is 5 days, so that's not treatment, but they're starting to do things like teaching safety planning and some brief interventions, so that when people leave the hospital, A, they have a better experience, and B, they actually get some treatment. And lastly, the risk for suicide is high after hospitalization in the 3 to 6 months after. And so if we give them tools to manage those thoughts and they're getting help, maybe we can lower that risk as well.
And building on that topic, one of our attendees asked, Dr. Jill, is there a protocol for patients who end up in the hospital after a suicide attempt? We had a situation where a patient was released to their family after 2 attempts. Unfortunately, we lost her in her own home. It's hard to imagine why she was released to her home. How could family members be qualified to care for her in that mental state? No.
There is no one protocol because every person is unique. And unfortunately, we only know maybe when there are going to be periods of risk and maybe who is at risk in their life, but we don't necessarily know in the moment. And I think that's a very hard position for family members, even if the person doesn't make it another attempt or sadly die. And I'm so sorry for your loss. It's incredibly stressful, which is the reason we came up with the Finding Hope program. For the very reason of what do you do when somebody comes home from the hospital? So there's a set of guidelines not guidelines, but guidance, and you can also find it on our website, to try and help the family as well as the person, because you're right. Even clinicians are not in a position to guarantee that somebody's going to be okay, let alone a family member. This is a problem with our treatment system that we don't have. We just talked about 2 seconds ago about how terrible it is in the hospital. We have to get people out. And so getting them help when they're out is also a problem because there are long waiting lists. And so it is a dilemma. I wish I had an answer and a good answer, but all you can do is do the best you can. And sometimes this just doesn't work. People themselves don't always know that they're actually going to take their life. So it's very scary when someone is at risk and sent home, but I wish I had a better answer for you. And we're funding research to look at that. So maybe in a few years, I will have an answer to that question.
Yeah. I'm going for so you guys know I'm scanning for the toughest questions, the one that we won't have answers to, but I think talking about them together and what are the future directions we all want to move into. So what would you recommend for supporting someone who refuses treatment partly due to stigma, despite having risk factors, mental health, past suicidal, chronic pain, alcohol abuse, but is not currently in immediate danger for hospitalization?
It's very hard to love somebody at risk, and you can't force someone. You can hope maybe they'll have a conversation with somebody that resonates with them. You can offer opportunities, but in the end, we can't force people into treatment. And sadly, that's one of the ways that we lose people to suicide. You try, and ultimately it's up to them. Even if they're not thinking properly, it's still in their hands.
And I would add that it is incredibly difficult when you see someone that you care about who isn't in a place where they're ready to get help or able or willing to get help, really trying to maintain that kind of non-judgmental stance with them, and continuing to check in periodically and see where they're at with things, with how they're feeling about treatment, how they're feeling about how they're doing. That could also be helpful in starting to maybe inch them towards a place where they're ready to think about treatment. But I think, you can't force someone to do something they don't want to do. And I think the more you try to force it, the more resistance you might face. So really trying to approach it with kind of love and care, and a non-judgmental stance can be helpful in many cases.
I so agree with that. And the other thing is, it helps to get help yourself, or at least have a place where you can talk about these things. I saw somebody said something about NAMI groups, but being with people who are experiencing a similar thing can be super helpful. And it's so important to take care of yourself, because you're not going to be able to help someone else if you can't help yourself. And I agree with Dr. Bettis. The more you push sometimes, the more they have to resist. So just letting them know in an ongoing way that you care, that you're there, that you'll help them if they change their mind. I like laying little pieces of paper with information around if they're in your house, and just give them the space to hopefully come to that on their own. But also you need to take care of yourself.
Questions coming to mind as I run outpatient anxiety treatment centers, and thinking of sort of, well, number one, that non-judgmental just availability, and it's so natural in the therapeutic process. This is what we do. And then when all of a sudden there are these risk factors and somebody's saying that they're considering harming themselves, and it's sort of this cross section between, my own antenna of risk factors and wants to fully be available to someone, yet you're doing this sort of screening and assessment. And then I guess what I'm saying not well is that I think as outpatient providers, there's this like, oh no, we're not trained, or this isn't what we should be doing. But then the next step is in person, which is a hospitalization, which isn't necessary. And then there's this whole gap in healing providers that feels like a challenge zone. So I don't know exactly.
Even if this is how I think of it. And when I'm talking with clinicians, I think about how many of you, us, have had someone who doesn't talk about suicide and you're really worried about them. And then how many of us have people who talk about suicide all the time and we're not worried about them.
Right.
So we are not in a position to be predictors, because a lot of times people themselves don't know they're going to act on it. So there are times when we know someone's at risk. We can't, as outpatient providers, we can't just hospitalize people forever, because risk can be a long time. And so we just kind of have to keep that open discussion. How are you handling it? What are you thinking? Let's take out your safety plan. Have you used anything? Oh, you're not talking to that person anymore. Let's put a new person on your safety plan. Your safety plan is a living document. For me, I use what I call my 4 words that guide me. And it helps me in this situation. And they are compassion, respect, patience, and persistence. And I think when you have somebody you care about who's not receptive, to have compassion as opposed to just empathy, where you feel what they feel, but understand that there's help available if they will take it, respect their capacity to take it up, and then be patient and persistent and don't give up. Like Dr. Bettis was saying, just stay connected. When people are in that state, they have what I call disconnection, but it's DYS connection. So, they are connected. They can say, I love you and you love me, but you'll be better off without me. And that, of course, if you love someone, or I'm a burden therefore you want me dead. I mean, it's just it's faulty assumptions there. And so remember, they may not be able to connect as well to you, or they have this kind of dysfunctional connection, but you can still connect to them. And sometimes just over time, or there are pockets of connection that help them to keep going.
Very nice connection.
Yeah.
Dr.
I
Bettis,
also think I'll add, kind of thinking from the clinician perspective, I think something that is important to get really comfortable with is just really integrating regular check-in and assessment around suicidal thoughts and self-harming behaviors into your practice. And I think sometimes, and I know that I got some of this in my training, you know, are taught maybe to only ask about it if you think you're seeing a warning sign, or if you think you're seeing a change, but making it something that is just a very normalized part of how you check in with your patients over time also helps to, I think, reduce the stigma of it. So it's not just, oh no, I'm only checking in when I'm really worried about you and things seem not to be going well. And that kind of builds on the stigma of talking about suicide, but really just making it, again, part of this non-judgmental check-in, and shows that you care about somebody, and that shows that you kind of notice that, you know, sometimes people aren't going to show these warning signs. And it's still important to check in and show that we're tracking that and thinking about that, and that it's okay to have those thoughts, even if things are going well for them, even if all this other stuff isn't kind of happening. So I know that's a little tangential, but just wanted to note that.
and maybe for a future webinar, but I think as an outpatient provider, part of it is there's a part of a legal concern, like, oh no, am I supposed to, am I supposed to then, I'm trying to judge like my gut of, all right, I feel like they're going to be okay, but is this a risk that I don't then have them do inpatient, and that might be too much for where they're at, and it could be traumatizing where they are okay. And so then I think then that connection sometimes gets severed a little bit more than I wish. I could just be available and not even be thinking of that at all.
So can I say
Yeah.
something about that? Because we're not expected to be soothsayers. We're not expected to know if somebody's going to do it or not. We're expected to assess for risk, which, by the way, risk can be long-term. You know, it's not like people right before they're going to take their life announce it. They may say it and not do it for 2 years, 10 years. So risk is an ongoing process. We are not required or expected to know exactly if somebody's going to act on those thoughts. We're expected to, and that's why looking at all the risk factors and not just thinking about what they're saying to you right then. Are they drinking? Are they having more pain? Are they having stressors like losing their job? And by the way, a lot of times those stressors happen because of the things that put them at risk, you know. So document, you know, they said this or they didn't say they were thinking about it, but I noticed that they're drinking more and they're not sleeping. So we took out their safety plan and reviewed it, and their risk is low to moderate. And I will be talking to them during the week to make sure to see how they're doing. That's what you can do. And no, you will not be, if you don't ask ever, that's when you're going to be liable. But if you ask and you document and you have a plan and address it, you'll never be considered, you know, you won't end up being considered liable because you're not the behavior police here. You know, you can't always know.
And I think I love all
really
of that.
helpful.
And I think what's also important to remember, and I think this again speaks to a real need for us to get training out there for everybody who's working with patients, that we need more resources to devote to training and making sure that people feel comfortable and equipped to do all of this, but also that suicidal thoughts and suicidal behaviors show up across diagnoses, right? It's not that it's only depressed patients or only patients with bipolar disorder that are going to experience this, but we've got patients with every diagnosis this can come up. It's truly transdiagnostic. And so that means that we should, as clinicians, all really be prepared and to address this, because it will come up if we're asking about it. in the
And I
submission
think,
form.
yeah, and to add to that, we can't just ask, are you thinking about it? Have you ever tried? And then they say no, and they're not at risk, because 60% of people who die by suicide die on their first attempt. So that's why it's important to have a full understanding of the person and not just rely on their yes or no. And then when you're working with them, and any thorough intake evaluation, you'll get all that information. You know, it's not like you have to do something special. You will get that information, and you ask them about past and present suicidal behavior. So we as clinicians watch all of it, not just, you know, if they're thinking about it or not. Because sometimes when they've made a decision, they're going to tell you no.
Right.
For sure, because they're not.
So I know Dr. Jill is off to another suicide prevention presentation, and we certainly have a lot of questions that we're going to get back good information to the attendees and to the world. So I am hoping for a part 2 at some point, because I've learned so much. I know that the attendees have as well. So thank you both for your expertise and all that you're doing, and hopefully looking forward to part 2.
And thank you both so much. It's I've learned, and I
Thank you.
appreciate people who are on to hear and learn and share.
Thank you all. To be continued.
Take
Thanks,
care.
everyone.
All right.
Bye.
Bye.